Good afternoon, everyone. My name is Tim Tuccaro. I'm the Associate Dean for Research in the Faculty of Health Sciences and a colleague of Dr. Greg Wellenius. Dr. Wellinius is the Director of the Center for Environmental Health and Technology and an Associate Professor in the Department of Epidemiology at Brown University. Greg is a colleague that has been working with us on climate change issues and trained at Harvard University and comes all the way from Providence, Rhode Island to be with us today. So Greg, thank you so much for coming.
Great. Thank you, Tim. Thanks for the invitation to come. I think Tim and I met about 2 years ago in Barcelona, so neither of our hometowns, and I've been sort of looking forward to coming to visit since, so it's a pleasure to be here. So today I'm going to focus on our work on the health impacts of heat, and in particular, what can we do about it? How do we move beyond describing the problem to actually doing something about it? So in epidemiology, we're really good at describing problems. We're naturally less inclined to do anything about them. So sort of my mission, in a way, is to sort of try to move the field in general towards more solutions than description. So as many of you will already know, excess heat is a recognized public health problem in the US. So apologies, most of my work has been in the US, but more people die of extreme heat each year than any other meteorologic event, or at least that's the conventional wisdom. We're actually looking to put some harder numbers on that. But we, as a community, have actually made fairly little progress in solving this problem. So here we have a recognized public health threat. We pretty much know who's dying and what they're dying of, and yet we're not doing very much, or we're not very successful at preventing these deaths. And this suggests to me that there's a lack of translation from this abundant sort of descriptive epidemiology into public health action. So just to give you a sense of sort of the state of the literature, this is from a large paper across more than 100 countries by Antonio Gasparini, who's at the London School of Hygiene and Tropical Medicine. And he looked in a number of countries at the relationship between heat and mortality. This is all-cause mortality. And what you can see is that in any given city, there's a temperature of minimum mortality. This is the temperature at which we see the fewest people die. And then the risk of death increases sharply as it gets hotter than that, and increases sort of more gently, more slowly at temperatures below that. So you have this MMT, or temperature of minimum mortality, and then this sort of U-shaped function where when it gets hotter than that or colder than that, you see increased rates of mortality. And you see,
Can you please tell us what the axes are? I can't read them.
Excellent, thank you. So on the x-axis here, you have the temperature in degrees Celsius, and the y-axis here on the bar graph would be the number of days. So it's just a frequency histogram, and then on the curves you have the relative risk of death. So the solid line, vertical line there indicates this temperature of minimum mortality, and the relative risk of death goes up on either side of that. Thanks for pointing that out. And you see a very similar relationship pretty much in every city in the world that has been looked at, although the shape might vary slightly. So some places like in Madrid and in Rome, you see relatively sharp increases in temperature, in mortality as the temperature goes up. In Bangkok, that was sort of gentler and less pronounced. In Stockholm, similarly, gentler slope and less pronounced. But so there's this general U-shaped relationship between temperature and relative risk of mortality. But exactly where the temperature of minimum mortality is and how sharp it increases on either side varies from location to location. And to give you sort of a close-up of that again, so you have temperature on the x-axis and relative risk on the y-axis. Here's two rather different cities. So you see that in London, there's quite a sharp increase at very cold temperatures, increase in relative risk of death, whereas in New York City, you don't see that entail there. But in both cities, you have an effect of heat. So we can quantify how many people die due to excess heat, so heat values above the temperature of minimum mortality, and how many people will die, are expected to die for temperatures colder than the temperature of minimum mortality. So in the US specifically, so this is a study by Francesca Dominici and her group at Harvard looking at extreme heat. So although there's this continuous relationship, oftentimes we focus the research on extreme heat events. And she's been using the Medicare data, so this is for seniors over 65 years of age and across the whole country. Very large database, and this was looking at all different types of hospitalization. So now we're moving from mortality to hospitalizations. And what you see here is the risk difference per 100,000 individuals, and versus here's the relative risk. And so the question there was, instead of looking at one outcome at a time, as many of our studies have been doing, let's look at every outcome and see where should we be looking. And fluid and electrolyte disorders, including things like dehydration, have the biggest risk difference here in terms of the number of excess hospital admissions among seniors. And it has a large relative risk, but it's not the largest relative risk. The largest relative risk is for heat stroke and other external causes. So these are things that are sort of coded as being related to heat. So on very hot days, physicians are more likely to code your visit to the emergency department as being heat related than a non-heat day. So that's not surprising. But it's actually, the risk difference is bigger for other things, including renal failure and dehydration and other fluid electrolyte imbalances. So this, I like this because, one, it's very comprehensive. It tells you about sort of all the causes, and things like, we thought that heart failure would be a big increased risk, but in fact we don't see an association in this population between heat and heart failure decompensation, which is really surprising because if you look at the mortality data, much of the mortality is due to cardiovascular disease, or coded as being due to cardiovascular disease, so we would have expected that. And then sepsis came up as a very unexpected positive finding. So this kind of analysis at the national level helps tell us where we should be looking in terms of what are people being hospitalized for, what are the impacts of heat.
And stroke did not even make your list.
Stroke was one of the null findings here, yeah. So there's about 100 other conditions in between here that were sort of unassociated. Yeah. And the literature on stroke particularly is very mixed. Seems to depend on location and population you're looking at. So what we know is from these sort of very large studies, global in some cases, very large national in other cases, is that extreme heat is associated with higher rates of death and hospitalization. That moderate heat, so even levels that don't reach to sort of the heat wave levels, but that are still hotter than this temperature of minimum mortality or morbidity. So these moderate days are associated with higher rates of death and probably with hospitalization. The data is a little less good on that. We know that the vulnerability varies by personal characteristics, by the type of housing, and by the characteristics of your neighborhood and your community. And we know, we'll touch on sort of how the climate is changing, but we know that the US has already warmed and is projected to continue warming into the future. So that's what we know. Now, as a policymaker, what would you need to know to actually do something about this? Well, most policy is set at the local level, actually. So as a local public health or emergency preparedness official, what you need to know is what's the current threat or risk associated with a given hazard in my community. The national studies is great for sort of establishing this as a problem, but as a local policymaker, you don't really care about the national effects, you care about the effects in your community. So what local actions can you actually take to protect people's health, and do these actions work? So we're going to try to close the loop between what actions people are taking and the evidence of whether they work, and how are these risks projected to change into the future. Okay, so we started our work in New England, so this is the northeastern part of the US with Massachusetts grayed out because they didn't participate in this particular study, but we had Rhode Island, data from Rhode Island, and 14 other communities in New Hampshire on this side and Maine on this side. So working with the departments of health in those 3 states. And what we were trying to do is provide local evidence about the threat of excess heat. And each of these places is too small to do this analysis on their own. So the population and the number of events in each of these towns is too few. If they tried to do it on their own, they wouldn't really find statistically significant or even necessarily meaningful results. So the only way this worked is by combining data across all these locations to pool the information and come up with something. And so overall, across these 15 locations, what we found is, again, here you have heat index. So heat index is relevant, at least in the US, because the National Weather Service uses the heat index as its metrics in most places on which to base heat warnings. So when we forecast high heat, it's based on this combination of temperature and humidity that's into the heat index. And on the y-axis, you have the relative risk or incidence rate ratio. And for emergency department admissions and for deaths, we saw the expected association that as the heat index gets higher, the relative risk of either ED visits or deaths increases. You can see the width of the confidence intervals here is pretty wide, even pooling data across the 15 cities or 15 towns, suggesting that in fact, in any individual town, we would not be able to study these effects in detail. The surprising thing is at how low the excess risk really, usually the National Weather Service issues heat advisories when the heat index is forecast to be 100 degrees or higher, okay, which could be sort of an 85-degree day with high humidity. So these aren't days that people normally consider, extreme heat, but we're seeing health effects, important health effects, at levels of the heat index even below those that are currently used. And we can quantify like how many people is that. So this is on this column, you have days at or above that particular value of the heat index, and this is how many excess ED emergency department visits you'd expect on all the days above, say, 90 degrees. So above, say, 95 degree heat index values of 95 degrees, we expect almost 200 excess emergency department visits per year. And for deaths above 95 degrees, we'd get an extra 12 across this region. So that's not huge, but the population in these towns is also not huge. We're talking about 2.3 million people living within the study area. So we went to the National Weather Service with this and said, look, you're issuing heat warnings and heat advisories when the heat index is forecast to be above 100 degrees, but we're seeing substantial effects even, say, at 90 degrees or 95 degrees. So that's just a summary of the results we did. And so the National Weather Service in this area is issuing heat advisories, as I said, at 100 degrees. And the goal of these is to provide information to the public and also to emergency preparedness officials. And sometimes the heat warnings certain levels of heat warnings will trigger additional responses like the opening of cooling centers or cancellation of sporting events, etc. But the optimal threshold at which heat advisories or heat alerts are issued isn't well studied. So the National Weather Service has sort of set national policy and national recommendations, but they encourage each local office of the National Weather Service to work with local stakeholders to figure out what are the optimal criteria for their area. So based on that, we went to the National Weather Service and said, hey, we have this evidence for New England. Could we modify the thresholds at which you issue heat advisories? And we were successful. So in summer of 2016 and beforehand, this is the New England region here, and the northeast of the US is this area in green, and that the guideline criteria for that whole region was the same. So whether you lived in Pennsylvania or West Virginia, which get quite a bit hotter than northern Maine, you were using the same guidelines to issue heat advisories. So when the temperature was forecast to be above 100 degrees for heat index. And so we said, look, this area is really quite heterogeneous, and we've shown you that in New England, we see a significant health impact at lower levels of heat index. Could we change that? And so there was a negotiation, back and forth, and they said, okay, yes, we can make this area in New England have heat advisories triggered by a heat index of 95 degrees or higher rather than 100 degrees. So we celebrated this. This felt like a major public health victory. We showed evidence and we changed policy. So that seemed like success, and it would be if heat warnings actually help prevent hospitalizations or deaths from heat. So then we started asking whether that's actually true, and there's actually been very few studies looking at the effectiveness of heat warnings. So there's this one study from Montreal. There's a handful of studies. One of the better ones is this one looking at the effect of heat warnings in Montreal. And what they found is using a difference in difference approach, which is a causal method that was appropriate in this scenario. This heat action plan, activation of the heat action plan, including a heat warning, was associated with about 2.5 fewer deaths per day on a very hot day than otherwise you would have seen. So that's important. It wasn't statistically significant, again, highlighting the challenge of doing this at an individual location because of the lack of data. So we said we need to look at this more, and we need to look at it across the country. And as a starting point, we said heat warnings are based on the forecasted heat index, not on the actual observed, but on the forecast. And forecasts are often wrong. And they don't need to be wrong by a lot, but you can have a forecast heat index of 102 degrees, and in fact it only gets to 99 degrees. So a relatively small error would mean that sometimes we forecast conditions that would warrant a heat warning, and we actually don't reach those conditions. And other times we forecast a day that's going to be hot, but not hot enough to trigger a heat alert, and so we don't issue a heat alert, but it turned out to be a couple degrees hotter. So there's a range of days there where we have very similar heat indices observed, but because of forecast error, sometimes we have a heat alert, sometimes we don't. Okay, so on these days with similar heat index, the rate of death lower if we have a heat warning versus not, given that we have very similar levels of the heat index. So to put this sort of more concretely, here is a graph of the heat index and versus relative risk. So this is made up data. So if you had a curve like this and we issue heat warnings above 100 degree heat index, we want to know if the relative risk of mortality is lower in the presence of a heat warning compared to the same day without a heat warning. Okay, so that's sort of the hypothesis we're trying to test here. The first challenge in doing this is that the National Weather Service didn't start keeping records of when they issued heat alerts until 2001. Okay, so before that they issued heat alerts, they just didn't write it down. In 2001 they started writing it down in this free-form text. This is actually just a record of all the alerts for any weather condition, lightning strikes, small wind advisories, heavy rain, etc. And it's all just in this sort of free-flowing text, and so this isn't feasible to do by hand. So we so most of this work has been led by Kate Weinberger, who's a postdoctoral fellow working in my group. And she said, okay, well, we can develop a text parsing program. This is basically minimalistic natural language processing because you can recognize keywords like heat advisory, you can know the location. This is for the Bronx, New York, or Brooklyn and Manhattan, Queens and Staten Island. You have a date. So you can take this information that is in slightly different form depending on the weather station you're talking about or the weather region you're talking about, but it's all there, and we should be able to parse it out. So that took some work, but we were able to compare that to manual extraction of the data and found that it performed very well in this automated function across several cities. So being able to recreate the time series of what days we had heat warnings and what days we didn't was really important. And then we combined that with mortality data for 211 cities from 1985 to 2006. So unfortunately, we don't have records of heat warnings before 2001, And unfortunately, we're not able to get mortality data from after 2006. So our study was limited initially to this 2001 to 2006 period, and we started it by just looking at the 20 cities that had the most heat warnings, because that's where we'd get most of the power anyway. So these are the 20 cities, so several in the northeast US, and then a smattering across the rest of the country, notably missing the Pacific Northwest and the middle of the country is because those locations, either middle of the country has low population, Pacific Northwest doesn't issue a lot of heat warnings. So just a list of the cities and the number of heat warnings. So we had Dallas-Fort Worth had the most heat warnings during this period, about 70, but we cut it off at about 20. That's 29 in Fayetteville, North Carolina. So the power in this analysis is related to the number of deaths, so population size is important, and the number of heat warnings. So that's sort of where we drew the line as sort of beyond this we have diminishing returns. And this is just to convince you that there are a range of days in any city that have similar levels of the heat index, and that sometimes you have a heat warning, sometimes you don't. So here's maximum heat index in bins, and this is the probability that a warning was issued. So when it's in New York City, when it's above 105 degrees, you always or almost always have a heat warning. There's no ambiguity about that. And on days below 90 degrees heat index, you never have a heat warning. But in between those values, there are a number of days that have some probability of having a heat warning. That's not 0 and it's not 100. Okay, so then we took a time stratified case crossover approach. I won't go through all the details, but I'm happy to talk about that afterwards if anybody wants to know. But basically, this is the principle here is that we're comparing the rate of mortality on a day with a heat warning versus without a heat warning, matching or adjusting for a lot of other factors that could be different between days. And what we found is, so here you have the percent change in the mortality rate, so with the null line being the vertical line there at 0, and to the right indicating that you have higher mortality during a heat warning day, and to the left indicating that you have a lower mortality rate during the heat warning day, compared to non-heat warning day in the same city. And what you see is that overall, there's no overall benefit to a heat warning. So a heat warning across these 20 cities in this time frame was not associated with reduced mortality compared to similarly warm days without a heat warning. Notable exception was in Philadelphia, where a heat warning was associated with about a 4% reduction in mortality rate that was statistically significant. But neighboring New York City, so very similar climate, presumably similar population characteristics, was not associated with the decline. And the overall was close to the null. Okay, so that was both surprising and challenging to publish, because that wasn't, null papers are always a little bit harder to publish, but also this flies against the intuition that we do this because it matters, we do this because it protects people, and here we're showing evidence that maybe overall, during this time period, it's not protecting people. And then we said, well, there's some variation, so let's do a meta-regression to see if maybe heat warnings are more effective where we have a higher mean daily maximum heat index, and there's no evidence of heterogeneity across that. Or maybe some cities have more air conditioning than other cities. Maybe there's some relationship there. Now, these are all underpowered because we only have 20 data points. But essentially, the AC prevalence, the population, fraction of the population over 65 years old, or the number of heat warnings issued, or here, the percent of the heat alerts issued that were warnings rather than advisories, none of these things sort of made important differences in the effectiveness of heat warnings. So we see that heat warnings are overall not effective, and we don't have a good predictor of which of these cities would it be more effective. Now, we've pursued this work. One of the major limitations is this cutoff of 2006, because most places that have implemented heat warning plans or heat action plans have done so after 2006. So this was an era where we had heat warnings, but not a lot of heat response plans. So we've teamed up with friends at Harvard and used data from the Medicare program, which again covers virtually all individuals over 65 in the US and from across the country. And we have much more recent data from them, so you can look at Medicare mortality or Medicare hospitalizations in 2 different time periods. This, as we're starting out, is limited to the Northeast, so 9 cities in the Northeast. And what we see is sort of very similar, that overall we didn't see a benefit of heat warnings in 2001 to 2006, but in the more recent time period, there's some suggestion of a benefit for mortality, and maybe we'll see when we do the rest of the country or more recent time period, maybe there's a protective effect for hospitalization. So what we can say with confidence is that in 2001 to 2006, during that time period, there was very little overall benefit of heat alerts, but there's some signs that that's improving over time as heat response plans get better and better. So, and that's just summarizing what I said, and we still have limitations of this type of analysis. So, for instance, people live in a city, and we know that not everybody is exposed to the same microenvironments, but our temperature data, our heat index data, and the heat alert applies to the whole region as a whole. There's the effects with temperature are actually complicated, so it's not just today's temperature, today's high temperature, but also maybe tonight's low temperature and maybe yesterday's high temperature that combine. So we have to do a better job at looking at lagged effects of heat. And in these initial analyses, we're underpowered for looking at meta-regression. So we've continued to work on this, and we hope to have some more results by the time we present some of this at the International Society for Environmental Epidemiology meeting in Ottawa in August. Okay, so that covers what is the current health risk associated with heat, what local actions people are taking. So heat warnings and heat response plans are an instrumental part of the protection against excess heat. Do these work? So far the evidence is limited, suggests that there's a big opportunity for improvement. And so now I want to talk about how is this risk likely to change going forward. So you're all familiar, I'm sure, with the Keeling curve. Keeling curve. This is measured carbon dioxide levels. The observatory in Hawaii has increased since measurements began, and in the context of the last 10,000 years, we haven't seen atmospheric CO2 levels as high as this for even longer than these 10,000 years. And the impact, of course, of accumulating greenhouse gases in the atmosphere is that depending on the rate at which we continue to accumulate greenhouse gases will dictate our future climate. These are now projections, so the black line is the actual observed, and these are projections under different greenhouse gas emission scenarios. They're scenarios and projections, not predictions, because it depends on the policy response which trajectory we're going to end up going towards. So RCP, this is representative concentration pathway 8.5, is one that essentially continuing emitting at the current rate. So this is the business as usual scenario, and we'll see that globally we will lead to significant average warming, and the local effects will vary depending on where you are. And then a much more, what we might call a mitigation scenario would be RCP 4.5, where emissions stabilize by about 2050 and continue seeing a bit of warming past that, but that this would be a stabilization scenario. And there's other scenarios in between those, and a more conservative one that's frankly implausible at this point. So the question that we started asking is, what is the impact? Because policy is made at the local level, we need to know what the problem is, what the challenge is at the local level. And there's good numbers for how many people would die of excess heat in across the country. But again, local policymakers need local information. So this was the undergraduate thesis of a student that worked with me, and so she looked in 10 cities across the US. And just to, again, highlight what we're doing here, so we have mean temperature now, we're back to temperature rather than heat index, in degrees Celsius along the x-axis, and this is a frequency histogram of the number of days at each temperature. This is a curve with the relative risk of mortality relative to this temperature of minimum mortality here, with the red showing the temperatures above that minimum and the blue showing the temperatures below that minimum. And you see rather different curves in Los Angeles and Boston. You see that the temperature of minimum mortality is lower in Los Angeles than in Boston, and sort of but Los Angeles gets hotter, so this part of the curve is lower. Bigger. The scales are a bit different, so it's hard to tell. Boston gets a lot colder, so this might just be compressed. But we can use that again to quantify how many more people are dying of heat and of cold. If the whole temperature distribution shifts to the right, which is what we expect in these cities, we should have some fewer deaths related to cold and some more deaths related to heat. And so we can put a number on that. And so in Los Angeles, for instance, this is the number of excess heat-related deaths. So this is now in 2050 or 2090, under the more conservative mitigation scenario, RCP 4.5, or under the business as usual, RCP 8.5. What you see is that you have a substantial number of excess heat-related deaths in Los Angeles, and some fewer cold-related deaths. So, not all impacts are necessarily bad, but the net, shown in the black diamonds, the net increase in mortality will be positive in Los Angeles. In Boston, now these are on the same scale, same y-axis scale on the left side, you see some slight increase in heat-related deaths and some small decrease in cold-related deaths, and on average it's pretty flat. So we'll see some increase in heat-related deaths, some decrease in cold-related deaths, but the net change will be essentially zero. So again, emphasizing the importance of local information. This is just another way to view those same pictures, and here is now the increase in mean temperature added. So these are the same plots I showed you in the last two slides, but now inserted here is the mean change, and the change in temperature is actually not that different in Boston and in Los Angeles. And this is too small to see in detail, but just to show you that we did the 10 cities and that in most cities the net change is positive. But in a couple cities like Atlanta and Boston, you essentially have zero net change. It also tells us where we have a lot of uncertainty and where additional information would be beneficial. So if you're a planner in Miami, you would be interested in finding better information that would help you pinpoint this more precisely. These are all on the same scale. Okay, and then we can use that to quantify the number of excess either heat-related deaths, the reduction in cold-related deaths, or the net change. And so this is the net change of temperature-related deaths. And so we see overall across these 10 cities, which represent about a quarter of the US population, we'd see an excess, there were 29,000 temperature-related deaths across that region, and that should increase to 32,000 by 2050 or 43,000 by 2090 if we assume the population of today, so assuming no adaptation and no population growth, both of which are not realistic assumptions. And we could also take projections of population growth. Of course, that's subject to additional error, but then the numbers get even bigger in terms of what the number of excess temperature-related deaths that we might see. So this is a huge problem across the country, but it's also a huge problem in some individual cities. Okay, so I think I've said all that. The key point is, and what we're trying to show, is that there is a health benefit to adhering to a lower greenhouse gas emission scenario. So we always talk about the cost of mitigation, Yes, it will cost money to transition to a less carbon-intense economy. But there is a health cost, and in fact a dollar cost associated with that comes from not adhering to a greenhouse gas emission scenario. People don't like to hear about bad things, so we turn it around and talk about good things. This is the number of lives you could save and the number of dollars you could save by adhering to a lower greenhouse gas emission scenario. And that's a much more positive message. It's of course just a reverse of the doom and gloom, but I think it's a message that resonates better with policymakers as an opportunity to save lives. We should want to do that. Okay. Sorry. I'm going to switch to those previous data were related to mortality. We also care about non-fatal events, and as we get better at preventing deaths from heat, we care about the emergency department admissions. So that now those data are harder to get. So this is in Rhode Island, and we have deaths and ED visits. And again, we see that the relative risk of death is from temperature extremes is much higher than the ED visits, but because ED visits happen much more often than the actual population attributable number, the number of ED visits you might prevent are actually potentially much higher. You also notice that the temperature of minimum mortality is very different. Here, it's about 22 degrees Celsius, whereas for ED visits, it's closer to 10 degrees Celsius. So where your body's sort of most comfortable in terms of death is different than the set point for ED visits. So this means that the impact of future climate change could be very different for deaths compared to ED visits. And in fact, so we did that analysis, and that's what you see. This sort of confirms what we did in a different data set in the last project on a bigger scale, that essentially we'll see some increase in heat-related deaths, some decrease in cold-related deaths, and on average about 0. But for ED visits, we'll see a small decrease in cold-related ED visits, but a big increase in heat-related ED visits. And on average, that's a net worsening in terms of the number of temperature-related ED visits. Okay, so we will see increases in heat-related morbidity and mortality virtually across the country from these and other data. We'll see in many places decreases in cold-related morbidity and mortality, and the net change will depend on the location, the population you're talking about, the time period you're talking about, and the outcome being considered. And quantifying these impacts at the local level is really important for local policy. So we've been talking a lot about heat, but there's of course more to climate change than just heat, and more to meteorology than just heat. So we want to expand that repertoire and do something similar for a number of climatic hazards. We're calling this the climatic hazardscape. I don't know if the term will stick, but I kind of like it. So this is the average number of days per year with temperature greater than 90 degrees, again in New England. And you see, so the Boston area is here. This is the Connecticut River Valley there, with Hartford, Connecticut being there. And the distribution, what's interesting here is that the distribution of that is not a pure south to north gradient. And it's very different than, say, this is the average number of days per year with very heavy precipitation. So this is 2.5 centimeters or 1 inch in summertime rain, which is enough to cause some minor flooding as well as potential combined sewer overflow or outflows. And you see again that there's a spatial distribution even within the small New England area, but it's quite different than for temperature. And if you think about ozone, now the distribution for high ozone days is again different than those two, with clearly now a south to north gradient. And then if you look at PM 2.5, this is fine particulate matter. You see what you'd expect is that around urban centers and major transportation intersections, you see higher levels of PM 2.5, but again, a very distinct gradient. And so we can put those together with the social vulnerability index. It's like the risk of having a health impact of these exposures is not the same everywhere. In fact, so there's many social vulnerability indices available. This is one that's publicly available from the Centers for Disease Control. And you see that there's some very high risk areas or high deprivation areas in northern Maine, and then in selected areas around the more metropolitan areas. And so you can put this together to try to come up with, if you have a limited amount of resources for mitigating the health impacts of climate change, where would you focus? You'd focus on some combination of where the exposure is highest. So maybe if you're concerned about temperature here and here, if you're concerned about ozone, the whole southern coast of New England, if you're concerned about PM 2.5, more in the urban regions. So if you can come up with policy solutions that mitigate multiple of these factors, and particularly target those areas that are at greatest risk of having an adverse effect, now you can take your mitigation dollars or your adaptation dollars, depending on your context, and apply them to where you're going to do the most good. Okay, that's hard to do. We haven't come up. We're trying to come up with an index that helps you target that. We're not quite there yet, but that's where we are. Want to touch on that most of the research to date on heat or on temperature health effects has been based on the temperature at weather stations, and weather stations are often located at airports because that's where we need high quality meteorologic data so planes can safely take off and land. So this is an example from Los Angeles. It turns out that people don't live at airports. They live in population centers that are often removed from the airport specifically. The airport is put where fewer people live to have that space. And here you can see that the temperature in the areas of LA where more people live can be substantially higher, or in some areas cooler than where you'd predict that's LAX there, where you'd predict at the weather stations. So the question is, how does this impact our health effects research, which has been based largely on weather station data? So this is the same type of curve. Now we're comparing station data from either in Indianapolis or from LAX in the Los Angeles area to this gridded climate data set that you see on this slide. This is on a 4-kilometer grid. There's higher resolution versions available, but we've been working with the 4-kilometer grid. And you can see that the relationship between temperature and relative risk in Indianapolis is essentially the same, whether you use the gridded climate data set to predict where people actually live, the temperature, or the station data. But in Los Angeles, where the airport is and the weather station are on the coast and often cooler than downtown LA, you see that in fact you would get a very different curve. So when we think here are the health impacts of heat, in fact, in some areas we probably have it right, and in some other areas we probably have it not quite right, and whether we're overestimating or underestimating as a whole across the country remains to be seen. That's an ongoing analysis. We're trying to say what would be the more accurate population-based estimates rather than weather station-based estimates. Okay, so we've covered all these points. The risk is changing, and we need to do a better job of incorporating across multiple climatic hazard domains and combine that with social vulnerability. And really highlights the challenge of translating this great evidence base that already exists and that continues to grow into actions that actually save lives. And we need to continuously be challenging ourselves to evaluate the benefits of those actions and whether we're actually investing our limited resources in the actions that make the biggest difference. Of course, I'm representing a very large group of very talented individuals. A lot of this work has been done by Kate Weinberger, a postdoc in my group. We have other postdocs, staff, doctoral students, undergraduate students, faculty in other departments, help from friends in other places. Antonio I mentioned, our friends at Harvard, and then stakeholders in departments of health in other cities. And so we really can't do this without bringing together large teams. This is sort of team science at its best. With that, I'll stop and be happy to take questions. Thank you.
Well, thank you very much, Greg. We will have some time for questions, and I realize I was remiss in thanking PICS, the Pacific Institute for Climate Solutions, for sponsoring this seminar and for providing lunch. I'm sorry about the people online who are not able to virtually eat pizza. So, questions for Greg?
Just a quick question.
Yeah.
Can you elaborate a little bit more on the mechanism between sepsis and heat waves?
The short answer is we don't know. Even in that paper, the authors said this was a surprising finding, needs to be confirmed. Particularly when you're looking in an older population like the Medicare population, there's many comorbid conditions, and the coding of sort of what pushed you over the edge, hard to say. So there's also coding isn't a perfect process because it's used as the basis for reimbursement of costs, and so there is so it's not that those people necessarily didn't have sepsis, but they might have had other things as well. So whether it's actually due to the sepsis or whether this is a particularly vulnerable population that happened to come in for their sepsis, because of the additional sort of health stress of the heat, honestly, we don't know.
Yes, administrative data has its limitations.
Exactly. I mean, it's great because of the sample size, the 100% representation, the national coverage of it, and the access to it. And so we can use it for a lot of great things, but it's always going to be limited.
Thank you.
In your 2001 to 2006 data, Philadelphia actually stood out.
Yeah.
And as I recall, Philadelphia was one of the early adopters
Yep.
of heat warning.
Yep.
Did you get into that any deeper?
Yeah, so Philadelphia has a long history of caring about heat and having implemented heat response plans probably before virtually any other city in the U.S. They also have a different process for issuing heat warnings. It's not just based on the heat index. They call it the Kalkstein procedure. It's basically a model that predicts what are the weather patterns that are going to lead to the greatest number of excess deaths. And on those days, we're going to warn people. So it's not all heat is the same. You have drier heat, coming with air masses coming from this direction versus that direction, and they use all that information to predict what will be sort of the impact of this day's heat and use that. So whether their heat warning system is more effective because it's issued at a more appropriate days, or whether the city actually takes more action in response to those heat alerts, or whether people are just more attuned to, oh, it's hot and it matters because we remember the heat wave of whenever it was, unknown. And so we were excited to find that Philadelphia was exactly where you'd expect to find a benefit if there was going to be a benefit. And the reviewer very astutely said, look, you looked at 20 cities, and you found that 1 out of 20, or 5%, had a p-value of less than 0.05. So of course we want to believe that it's because it's Philadelphia and it means something, but it could just as likely be that you were, because you used a p-value of 0.05, you had a 1 in 20 chance of seeing something. So to be confirmed. New York City has also developed a very strong heat action response plan, and so when we sort of compare Philadelphia and New York City in the more recent time period, it'll be interesting to see if they're more similar, and if Philadelphia continues to sort of stand out as a place. But in Philadelphia during that time period, those heat warnings, if that association is causal, would have prevented about 50 excess heat-related deaths. So it matters. And if you look at the other 19 cities, if they had heat warning that were as effective as those in Philadelphia, they could have potentially saved an additional 200 lives during that time period. So this is, if these things were causal and could be translated to other settings, there's the potential to save a substantial number of lives.
Yeah, I have 2 questions regarding the projected heat mortality. So you showed that there is a large difference between cities. I think you highlighted LA versus Boston.
Yeah.
So do you have any idea what causes these cities to be so different? So why do excess death increase in one case but not in the other?
Yeah, so I think part of the answer to that is the fact that LAX is systematically cooler than the bulk of the population, whereas in Boston we don't see that difference. Boston Logan Airport is on the water, but it's very, very close to the city. And in fact, in Boston, when we've tried doing the analysis with other weather stations that are downtown, we see essentially the same results. So I haven't, I showed you sort of the gridded versus weather station data sets give different answers in LA. I haven't tried that for Boston yet. It's coming, but my guess is that in Boston we won't see a big difference. So I think that's why it's really important to use these gridded or sort of national coverage data sets of temperature and humidity, because I think I don't think that there's a systematic error with using the weather stations, but I think that for any location we might be getting an incorrect or a less precise response.
So which leads me to the other question then for your, so you probably need downscaled climate projections to be able to do this analysis.
Yes.
So what data did you use?
So we've been using the CMIT-5. This is the comparison, I forget the acronym, but it's a 38 climate models, and what we do is we take the we use each one separately, and then we use a bootstrap approach to say, okay, there's uncertainty in the climate projection. So even within a given RCP and given existing sort of starting conditions, the 38 different climate models will give slightly different answers. So we'll incorporate that uncertainty into our effect estimates.
Okay, so you're not downscaling that.
We are. It's sorry. So it's downscaled to the 1/8 of a degree, which depends, how where in the world you are, how many kilometers an 1/8 of a degree is. But that's the finest resolution available, is daily projections at the 1/8 of a degree.
Okay, good. Then I just had a comment. So you left RCP 2.6 out.
Yes.
But that's actually a very interesting one, because sort of you had this 2-degree threshold in your graph, right?
Yeah.
Because that actually sort of is the one that leaves you below 2 degrees. So
Right.
if you have information of that scenario, it could actually show what the benefit
Right.
is of actually staying under.
Yeah, and the IPCC pushed for like a 1.5 degree, both in the Paris Agreement, but in the IPCC pushed for, let's say, what would be the change necessary both in emissions, and then what would be the health benefits of adhering to a 1.5 degree scenario. We haven't done that. I think that'd be interesting. Honestly, sort of where sort of the viewpoint from the U.S. is that would be almost implausible to achieve that.
I
right
just
now.
come back from the IPCC 1.5 degree meeting.
Oh, okay, great.
So
So you're right.
So
So I think it would be
So
interesting. The question is
yeah.
whether it's relevant. It's really interesting. It's ambitious. Are we on course to meet that? My guess is not, but I'd be convince me otherwise.
The 2 degree target is in the Paris Agreement,
Of course,
right?
of
So there's
course.
a policy
Right,
goal,
right.
so showing sort of what you would gain by actually sort of meeting that goal. I
That's
think
right.
whether the U.S. is on board or not.
And I understand that the
would be
climate
interesting.
agreement, the Paris Agreement, all the sort of commitments to date don't even get us to the 2 degree warming, right? So we're not on a trajectory to even meet the 2 degree goal. So looking at the 1.5 degree goal seems, on one hand, sort of like a useful exercise, but in terms of a policy driver, would it be more convincing than the sort of RCP 2.6? I wish it was. I'm not sure it is. Yeah.
So in your presentations, you touched on climate adaptation.
Yes.
So just wondering, have you, or if there's any studies out there that look at the impact of adaptations versus mortality rate?
Yeah, so that's a great question. It's about adaptation and how you factored that into your projections, and it's really challenging. It depends on, I would separate it out that there's probably some physiologic adaptation and sort of behavioral adaptation. The physiologic adaptation is, my wife is Canadian, and so, and we live in Boston, and she's like, oh, this isn't cold. It's not as cold as it used to be in Canada, right? So there's physiologic adaptation that comes with that. But then there's also the fact that sort of many places in the US that get hot enough have air conditioning. Virtually everybody has air conditioning. So how much room do we have left for physiologic adaptation? There's a threshold above which you just cannot evaporate the heat. You cannot cool your body above some ambient temperature. So there's limited scope for physiologic adaptation, and then there's limited scope in many places for further behavioral adaptation through increased air conditioning prevalence, because we're already at 100% and we're still seeing people die. So one approach that people use to some effect is saying, well, what if Chicago had the temperature and air conditioning characteristics of today of Houston? So what if Chicago in 20 years looked like Houston did 10 years ago? So sort of this analog cities approach. And that works to some degree, or that gives you one set of insights, but of course there's lots of differences between cities. It's, besides sort of just their temperature and their air conditioning prevalence. So that analog cities approach is challenging. You can also say, well, let's assume that in New York City, for instance, we've shown, or not we, the field has shown that there's been a big decrease in the relative risk for a given change in temperature, like for a given heat wave. It has a much smaller relative risk of death today than it did then. So let's assume that we could further reduce that by 10% or 20%. What would that do to the projection? So you can make sort of some of these guesses or assumptions and do it under different scenarios, but for now they're still assumptions because we don't really know exactly how much of the effect is sort of physiologic adaptation versus behavioral or structural adaptation. So it's a really challenging problem. Some really great people working on it.
It's also complicated by the adaptive capacity of humans in different places being widely different.
Yeah.
So the adaptive capacity of someone in Houston is different from Chicago when it comes to heat, and what's all behind that. The reasons are physiologically are not understood.
Yeah.
But there's something about acclimatization.
Right. Like, we know it's not all air conditioning. We know that air conditioning has accounted for a large chunk of sort of the adaptation we've seen historically, say in the last 100 years. You know, many fewer people die of heat today than they did 100 years ago. And one interesting question is the pace of adaptation keeping up with the pace of climate change. And that probably varies by location. And again, an interesting paper sort of somewhere on the burners, the back burners. But it'd be really interesting, right, to see, like, we know we're warming, we know we're adapting, but which is faster, which is winning? I don't know.
Just related to the deprivation index that you showed, there's also good evidence that while people may have air conditioning, it doesn't mean they use it.
Yes.
Even when they have chronic obstructive pulmonary disease,
Yes.
is one of the studies. So a medical condition where the air conditioning clearly would benefit, but they can't afford to use it.
Yes, so I think that's a great point, is that 100% air conditioning prevalence doesn't mean 100% air conditioning use, and there's two dimensions to that. One is the cost, which you correctly point out that there's many people that just can't, even if you give them an air conditioner, they can't afford the electricity bill that comes with it. And so Kaz Ito at the New York City Department of Health has been thinking about we do energy assistance for heating in the winter, and that's like a no-brainer. Like, nobody would say, no, we shouldn't help people pay their heating, but we don't do the same energy assistance in the summer to prevent heat-related events. And maybe if we start thinking about it in the same way, that sort of we have these cold effects that are well recognized, we have these heat effects that are well recognized, but we're subsidizing preventing the cold-related events and not the heat-related events. Sort of the equity there is an interesting consideration. The other one is that you have many people that just so we all work in air-conditioned buildings, but you have your roofers, your landscapers, your all sorts of outdoor workers, agricultural workers, toll collectors, policemen, firemen, etc., that are constantly outside, and that air conditioning won't protect people outside, right? And we think that this is a particularly vulnerable population. I was complaining to Tim earlier that when my kids play soccer, the parents are all fanning themselves on the sidelines under a tree, and the kids are out running in the full blazing sun. And so even when you think of outdoor populations, it's even outdoor recreation is potentially a challenge, and we don't think of that. Like, the league my kids play with don't have stopping rules for high heat. They do at the very high heat levels, but at levels where they should be seeing, adverse health effects, they don't have protective guidelines for that. So, I think it's a real problem. Schools typically in New England are not air conditioned. So you have kids on some very hot days. Even if the hottest days are in August when schools are out of session, you can still have really hot days in May and June in New England, and the schools are not air conditioned. What does that do to kids' ability to learn? So we've touched the tip of the iceberg talking about mortality and hospital admissions, but there's all sorts of effects on there's lots of evidence now suggesting that heat impairs judgment, and so you have more violent crimes, you have more car accidents, you have more occupational injuries. And so we think that these health effects, as we sort of continue to cast the net wider and wider, we'll find that mortality was just the tip of the iceberg, and that interventions that are targeted at reducing mortality and morbidity might also be effective at reducing some of these other wider effects that may be smaller relative risks, but will affect a much larger number of people, so sort of the total population impact can be really big.
Okay, great. I think that's got it. You've heat exhausted everyone.
All right.
Thank you very much.
Thank you so much.